In the ruins of Queen Hatshepsut's temple at Deir el-Bahari, carved into stone around 1458 BCE, there are murals depicting ships returning from the land of Punt. The cargo they carried was not gold, not spices, not silk. It was sacks of a resin. The same resin that Indian physicians had already been prescribing for joint inflammation for 300 years before those ships were even built. The same resin that Chinese physicians called ru xiang, prescribed to activate blood and relieve pain. The same resin that Persian doctors, Mughal healers, and European herbalists all independently arrived at, across 5,000 years and 4 continents, for the same cluster of conditions. We call it frankincense. The pharmaceutical industry has spent 30 years not wanting you to know what the research actually says about it. In 1991, a German pharmacologist named H.P.T. Ammon published the mechanism. He identified the exact enzyme that Boswellia serrata resin blocks, 5-lipoxygenase, and the inflammatory molecules that enzyme produces, leukotrienes. The same inflammatory molecules targeted by Singulair, one of the most prescribed asthma drugs in history. Boswellia blocks their production upstream before they even form. In 2020, a meta-analysis pooled 7 randomized controlled trials, 545 patients. The results were consistent, statistically significant, and in several head-to-head comparisons, superior to ibuprofen. Ammon put it plainly in his 1991 paper in Planta Medica. The results confirm the traditional use of Boswellia serrata in inflammatory conditions. 30 years later, it still isn't in a single clinical guideline for arthritis. This is the Lost Dispensary. We find what was buried. Today, the mechanism, the clinical evidence, and exactly how to use it. Because the conversation you never had with your doctor can happen right now. Here's what we'll cover. 5,000 years of documented use across independent civilizations. The suppression trail that kept this out of guidelines. The biology that explains why it works differently from anything you've been prescribed. And a precise protocol based on the clinical trial data. Quick thing, if you want more recovered knowledge like this, hit subscribe. It's free, it keeps this channel alive, and I promise to keep digging. The Charaka Samhita, one of the 3 foundational texts of Ayurvedic medicine, compiled around 700 BCE, classified a resin-producing tree called Shalaki for what it called Sandivata. Sandhi means joint. Sandivata describes exactly what modern medicine calls joint inflammatory disease, osteoarthritis, rheumatoid arthritis, and related conditions. The text was written 700 years before the birth of Christ. 100 years later, the Sushruta Samhita prescribed the same resin specifically for cough, asthma, and intestinal inflammation. It also used it topically for wound healing. A later reference text, the Bhavaprakash Nigantu, listed it for bone degeneration and chronic glandular swellings. Those ancient Indian physicians had no idea what a leukotriene was. They had no concept of a 5-lipoxygenase enzyme. They had no blood pressure monitors or inflammatory biomarker panels. And yet they found this resin. They documented its effects. They developed specific fat-based preparations to make it work better. And they passed that knowledge down, continuously, for 3,000 years. Because it worked. Across in China, the same resin appeared in traditional Chinese medicine as ru xiang, prescribed to activate blood, relieve pain, reduce swelling, and resolve stasis. That phrase sounds metaphorical to modern ears. What it describes in clinical terms maps directly to reducing inflammatory infiltration and improving tissue perfusion. Precisely what the active compounds in Boswellia resin do at the molecular level. The ancient Chinese physicians were right. They described the mechanism in the language available to them. In Persian medicine, it was called kundur. Mughal-era Unani physicians used it for arthritis, both topically and orally. By the 16th century, European herbalists were documenting it for rheumatic pain. By the mid-1800s, the British East India Company had catalogued Boswellia serrata in official pharmacopoeias. 5,000 years, multiple independent civilizations, same plant, same applications, same results. Then, in 1897, a chemist at Bayer synthesized acetyl salicylic acid, aspirin. The pharmaceutical industry had just discovered something it had never had before: a medicine that could be manufactured, owned, and sold at scale. Over the following decades, Ayurvedic and traditional herbal preparations were systematically recategorized as folk medicine, not because the evidence was weak, but because the evidence wasn't structured in the format the new scientific establishment required. And nobody was going to fund the trials needed to reformat it, because nobody could own the results. For most of the 20th century, Shalaki sat in Indian grocery stores and Ayurvedic clinics, available to anyone who knew to look, while the Western medical establishment prescribed ibuprofen. Then Professor Ammon started asking questions. In 1991, his team published in Planta Medica, one of the oldest pharmacognosy journals in the world, identifying Boswellia's inhibition of 5-lipoxygenase. In 1992, his group identified the specific active compound, AKBA, 3-O-acetyl-11-keto-beta-boswellic acid. In 1996, Safehi and colleagues published in the British Journal of Pharmacology the inhibitory constant for 5-LOX, 1.5 micromolar. A potent, specific value. 3,000 years of empirical medicine, now confirmed at the molecular level. Boswellia doesn't work like ibuprofen. It doesn't even work on the same pathway. And that difference is more important than most people realize. Ibuprofen blocks the COX enzymes, cyclooxygenase 1 and COX-2. Blocking COX-2 reduces pain and inflammation. Blocking COX-1 removes the protective prostaglandin layer in your stomach lining. That's not a side effect. That's the predictable consequence of removing a protective biological function. Long-term NSAID use causes ulcers, GI bleeding, and intestinal damage by design. AKBA from Boswellia blocks the other branch of the inflammatory pathway entirely, the 5-lipoxygenase branch that produces leukotrienes. It does not touch COX-1. It does not remove the stomach's protective prostaglandins. In clinical trials, GI side effects with Boswellia occur at rates comparable to placebo, not lower than ibuprofen, comparable to taking nothing at all. But here's the part that should stop you. NSAIDs accelerate cartilage destruction. The prostaglandins they block include PGE2, a signal necessary for chondrocyte survival. Chondrocytes are the cells that maintain cartilage. Chronically inhibit their survival signals, and cartilage degrades faster. Long-term NSAID use is associated with accelerated joint space narrowing on imaging. The drug treating the pain is accelerating the disease causing the pain. Boswellia does the opposite. Through its reduction of MMP3, matrix metalloproteinase 3, the enzyme that physically degrades cartilage matrix, Boswellia provides anti-inflammatory benefit while simultaneously protecting the joint structure. In a 90-day randomized controlled trial using an AKBA-enriched extract called 5-loxin, researchers measured MMP3 levels directly in the synovial fluid of osteoarthritis patients. At 90 days, the 250 mg per day group showed a 46% reduction in MMP3 concentration compared to placebo. That is a measurable reduction in the enzyme destroying the cartilage inside the joint. And one more comparison. NSAIDs carry an FDA black box warning for cardiovascular risk, increased risk of heart attack and stroke, even with short-term use, even in patients without pre-existing cardiovascular disease. That warning was strengthened in 2015. It applies to ibuprofen, naproxen, and diclofenac. No equivalent cardiovascular signal exists in the clinical trial literature for Boswellia serrata. Not in the individual trials, not in the meta-analyses, not in 3,000 years of documented use. Ibuprofen. FDA black box cardiovascular warning. Documented cartilage destructive effect. GI ulceration with chronic use. Boswellia. No cardiovascular signal. Cartilage protective. GI side effects comparable to placebo. One of those is recommended as first-line therapy for osteoarthritis in clinical guidelines. The other is classified as alternative medicine. Let's look at the evidence. The first major trial, a double-blind, placebo-controlled study published in 1998 in the European Journal of Medical Research. 40 asthma patients, 6 weeks, 300 milligrams of Boswellia resin extract 3 times daily versus placebo. Results: 70% of the Boswellia group showed clinical improvement, not just in symptoms, but in objective lung function measurements, FEV1, FVC, peak expiratory flow rate, eosinophil counts. These are measured numbers. Lung function either improved or it didn't. In 70% of patients, it did. In the placebo group, 27%. Remember, Singulair works by blocking the receptor that leukotrienes bind to. H.P.T blocks leukotriene production before they even reach that receptor. The mechanism is upstream of the mechanism targeted by the prescription drug. And it worked in 70% of asthma patients in a controlled trial. For osteoarthritis, a 90-day double-blind randomized trial published in 2008 in Arthritis Research and Therapy, the Journal of the Arthritis Society of America. 75 patients, 3 groups: placebo, 5 loxin at 100 milligrams, 5 loxin at 250 milligrams. Both active groups showed statistically significant improvements in pain and physical function. The 250 milligram group showed significant pain improvement at day 7. 7 days. For inflammatory bowel disease, a 2001 randomized double-blind trial from the University of Heidelberg compared Boswellia extract to mesalazine, the standard pharmacological treatment for active Crohn's disease. 102 patients. The Crohn's disease activity index dropped by 90 points in the Boswellia group versus 53 points in the mesalazine group. The study authors concluded that Boswellia appeared superior to mesalazine in the benefit-risk evaluation. A 2011 trial testing a different preparation for remission maintenance found no advantage over placebo. That distinction matters and is worth stating plainly. The evidence is stronger for treating active disease than for preventing relapse. For ulcerative colitis, a 1997 study from the same Tübingen group compared Boswellia resin to sulfasalazine. Remission rates: 82% in the Boswellia group versus 75% in the sulfasalazine group, with fewer adverse effects in the Boswellia arm. And the meta-analysis. In 2020, BMC Complementary Medicine and Therapies pooled 7 randomized controlled trials, 545 patients. Visual analog scale pain scores. Boswellia significantly better than control. P-value less than 0.00001. Womack pain, significantly better. Womack stiffness, significantly better. Adverse events. No significant difference from control groups. Several comparisons against active comparators including ibuprofen. Boswellia, comparable or superior. In 2025, a network meta-analysis in Science Direct pooling 20 trials and 1,633 participants confirmed modified Boswellia formulations produced significant improvement in pain, stiffness, and function versus other interventions. New trials still publishing. The evidence base is not shrinking. In 2002, the European Medicines Agency granted Boswellia serrata extract orphan drug status for peritumoral brain edema, inflammation around brain tumors. The highest drug regulatory authority in Europe looked at the clinical pharmacology and acknowledged sufficient evidence of clinical value. They were not wrong about the science. The designation just never reached the arthritis clinic. Why? The answer is not complicated. Boswellia serrata cannot be patented. It has been in the public domain for 3,000 years. Moving a treatment into clinical guidelines requires phase 3 trials costing over $100 million. Trials that generate a return only if the product is patent protected. No pharmaceutical company will spend that money on a resin any competitor can sell the day after approval. So nobody runs the trials. Without the trials, no FDA drug approval. Without the approval, no place in guidelines. Without the guidelines, the primary care physician prescribes ibuprofen. The economics explain the silence. No conspiracy required. Now here's what you actually do with this. The most important purchase decision. Standardization. Not all Boswellia products are equivalent, and some will not work. Not because Boswellia doesn't work, but because the product doesn't contain what the label implies. Look for the percentage of boswellic acids on the label. Standard extracts are standardized to 65% total boswellic acids, a solid baseline. The clinical trials used extracts standardized to 30% AKBA specifically, sold under brand names including 5-Loxin, Aflapin, Bospure, and Aproflex. Products that simply say Boswellia with no standardization percentage tell you nothing about active compound content. Avoid them. The single most common reason people try Boswellia and report nothing happened. They took it on an empty stomach with water. Boswellic acids are fat-soluble. Taking them without fat means absorbing almost nothing. Always take Boswellia with a fat-containing meal. Olive oil, avocado, nuts, eggs. This is non-negotiable. Here is something genuinely remarkable about this. The ancient Ayurvedic preparation method for shalaki involved blending the powdered resin with ghee, clarified butter, before consumption. Those practitioners had no concept of lipophilic absorption or pharmacokinetics. They discovered empirically, through thousands of years of clinical observation, that the fat-based preparation made it work better. Modern pharmacokinetics has now confirmed exactly why they were right. For further enhancement, lecithin-based phytosome formulations like Casparome increase plasma levels of active boswellic acids by 3 to 7 times compared to standard extract. If the condition involves neurological inflammation, this formulation is worth seeking specifically. Piperine, the active compound in black pepper, sold as bioperine, at 5 to 15 milligrams alongside Boswellia, can enhance absorption by slowing hepatic metabolism. Important note, piperine enhances absorption of everything you take with it, including medications. Separate prescriptions by at least 2 hours. Dosage from the trial data. For standard extract at 65% boswellic acids, 300 to 400 milligrams 2 to 3 times daily with fat-containing meals. 600 to 1200 milligrams per day total. For AKBA-enriched extracts at 30% AKBA, 100 to 250 milligrams per day. The National Center for Complementary and Integrative Health confirms Boswellia at up to 1,000 milligrams per day has been safely used in trials lasting up to 6 months. Timeline. The 5-Loxin trial documented significant pain improvement at day 7. Recent bioavailability-enhanced preparations showed effects within 5 days. Full anti-inflammatory effect builds over 4 to 8 weeks. Cartilage protective effects, the MMP3 reduction, become measurable at 90 days. This is the benefit ibuprofen cannot provide, becoming measurable at exactly the time frame that ibuprofen is accelerating damage. Cost. Standardized extract at 65% boswellic acids runs $15 to $25 per month. AKBA-enriched formulations run $25 to $45 per month. Traditional resin at Indian grocery stores labeled Shalaki or Salai Gugal costs $5 to $15 for a substantial quantity, the form ancient Indian physicians actually prescribed. Safety. Excellent across all published clinical trials. Adverse events occur at rates comparable to placebo. The most common is mild GI discomfort, virtually eliminated by taking it with food. Specific situations requiring caution. Pregnancy. Avoid medicinal doses, associated with potential miscarriage risk in large amounts. No clinical safety data for pregnancy or breastfeeding. Blood thinners. Warfarin, clopidogrel, Eliquis, Xarelto, therapeutic dose aspirin. Boswellia has mild antiplatelet properties. Disclose to your prescribing physician. Cytochrome P450 interactions. Boswellia may affect metabolism of certain medications through CYP2C8 and CYP3A4. Run your supplement list by your pharmacist. Transitioning from prescription NSAIDs. Work with your doctor on a transition plan. Do not discontinue prescriptions abruptly. Around 700 BCE, Indian physicians documented this resin for joint inflammatory disease, respiratory inflammation, and intestinal problems. They developed fat-based preparations because the fat made it work. They passed the knowledge down for 3,000 years because it kept working. In 1991, Ammon confirmed the mechanism. In 2020, a meta-analysis of 545 patients confirmed the efficacy. In 2025, new trials are still being published. And the European Medicines Agency, the highest regulatory body in Europe, formally acknowledged the clinical pharmacology in 2002. The knowledge was never lost. It was commercially inconvenient. A woman in her late 60s wrote to me last year. She had been managing knee osteoarthritis for a decade, cycling through ibuprofen, then naproxen, then a COX-2 inhibitor her cardiologist eventually flagged for her blood pressure. She started standardized Boswellia extract, 400 milligrams twice daily with olive oil, on a Tuesday. By the following Tuesday, she noticed something. By week 6, her morning stiffness had changed enough that she canceled a follow-up appointment she had scheduled to discuss stronger medication. She wrote, "I spent 10 years being told my only options were drugs with black box warnings. Nobody mentioned this. The herb wasn't lazy. The system that should have studied it was." The ancient Indian physicians who prescribed shalaki for inflammation also prescribed another herb from the same texts for the same conditions. Curcumin, from turmeric. NF-kappa B inhibition, the master switch for the entire inflammatory cascade. A complementary mechanism to ACPA's 5-LOX pathway. Combined Boswellia and curcumin formulations are the subject of active 2025 research showing additive effects. Same 2 herbs, same 3,000-year-old texts. 2 different mechanisms working on 2 different parts of the same inflammatory pathway. That's the next video. For this one, if this is information your doctor never mentioned, share it with someone who needs it. Which traditional plant medicine from your own family's culture do you want us to investigate next? Same pattern every time. Documented ancient use, dismissed by modern medicine. Mechanism now confirmed by research. Drop it in the comments. That's how this dispensary grows. The dispensary stays open. See you in the next recovery.